So I think Ian has very nicely set the stage about why long-acting drugs might be preferable to single tablet regimens for prevention and treatment of HIV infection, and I'm going to talk a bit about some of the potential downstream implications. First, these are my disclosures, and I'd like to say that this year has been really a fraught year in the United States, and I'm very pleased from this morning's New York Times to show you that there's a 93% chance that Hillary Clinton is going to win the election. So, let me just set the stage by bringing people up to speed with where are we with the use of integrase inhibitors in the treatment of HIV infection? Why are we relying so much on them? And what are the resistance implications of our current approach to treatment, and how might that then translate into the use of long-actings? So across the board, all of the treatment guidelines now recommend integrase strand transfer inhibitors as first-line regimens. These are the recently revised DHHS guidelines, and you can see that 4 of the 5 regimens that are recommended, if I can get the mouse to move here, are based on integrase inhibitor regimens. The same as the International Antiviral Society USA guidelines now recommend as first-line only INSTI-based regimens. The EACTS guidelines similarly have emphasized integrase-based regimens, and so do the BIVA guidelines certainly include all 3 integrase strand transfer inhibitors as among the recommended regimens. So it's pretty clear that these regimens have really advanced the field and also have taken the prime position in treatment guidelines. Well, what are the data on which these recommendations are based? Here are the 5-year final data from the START-Merck study that compared twice-daily raltegravir to efavirenz-based therapy, and you can see that at the end of the follow-up period, raltegravir persisted at having a greater suppression rate compared to the efavirenz regimen. And the elvitegravir in its initial formulation with TDF, so elvitegravir boosted with cobicistat, and I wonder if it would be better without the slippery thing here, compared either to efavirenz or to boosted atazanavir, came out spot on in terms of its efficacy, with a slightly greater increase in CD4 counts compared to efavirenz, has been seen in almost every study comparing other regimens to efavirenz. And with dolutegravir, there have been numerous studies. When compared to raltegravir, it is non-inferior, and the other trials have shown it to be superior to efavirenz. But the issue has really been around resistance. So we know that there is extensive overlap in resistance among the 3 currently approved integrase strand transfer inhibitors. And although the primary mutations selected by raltegravir and elvitegravir differ somewhat, they really share overall resistance patterns. And viruses that are resistant to raltegravir are almost always resistant to elvitegravir as well. And with a few exceptions, viruses that are elvitegravir resistant are also cross-resistant to raltegravir. And the more raltegravir and elvitegravir resistance mutations you accumulate, the greater the chance that you will be cross-resistant to dolutegravir, although as Mark Wainberg has shown and as limited clinical trials evidence has confirmed, the primary mutation selected by dolutegravir is this uncommon mutation at position 263. But more importantly, if you have a 148 and a 140 mutation and then accumulate additional mutations from prior exposure to these drugs, you will develop cross-resistance to dolutegravir. So if we look at the data from the trials, and I apologize, this slide's probably hard to see in the back, but if we go through the main pivotal studies and ask how was resistance how frequently was resistance observed. In the START-Merck trial, there were only 66 participants who actually had virologic failure. There were 9 in the raltegravir arm and 7 in the efavirenz arm who had failure with a virus load above 400 copies per mil, who then had resistance testing performed. And in the 4 who had integrase inhibitor resistance mutations from the raltegravir arm, 2 had the double mutant G140S, Q148H or R, and 2 had 143 mutations. And then in the efavirenz arm of the 7 who had resistance testing done, 3 had 103N mutations along with other mutations. So in START-Merck, although resistance overall was relatively uncommon because virologic failure wasn't common and successful genotyping was even less common, there was a similar rate of emergence of resistance to raltegravir as to efavirenz. If you look at the elvitegravir studies, and I'll just show one example, a similar scenario is seen. Here there were roughly 350 participants in each arm. Only about 5% had resistance testing done, 14 in the elvitegravir arm, among whom 8 or half of those sequenced, but 2% of the starting population had evidence of resistance, and 7 of the 14 who were genotyped in the elvitegravir arm had evidence of integrase inhibitor resistance. You'll note that the most common mutation here was this 92Q mutation, which is one of the secondary mutations for raltegravir. The 148 and 155 were uncommon. But overall, the prevalence of resistance at failure for the elvitegravir arm was the same as the prevalence of resistance to efavirenz in the comparator arm. Now, by contrast, in the study comparing dolutegravir and raltegravir, again, about 400 participants per study, relatively small numbers, 5 and 7% of protocol-defined virologic failure, and of those who were genotyped, there were only 8 in the dolutegravir arm and 18 in the raltegravir group. 1 participant in the raltegravir group had integrase inhibitor resistance and none in the dolutegravir group. Now, a lot has been made about exactly when the resistance testing was performed as opposed to previous studies, but even in clinical practice, the emergence of dolutegravir resistance at the time of virologic failure has been really quite uncommon. It really has been undescribed, I would say, among people receiving dolutegravir for first-line therapy. Now, that may not quite be the case in people who take dolutegravir for second-line regimens. Here in the single study, in the single study, again, which is treatment naive, now comparing single tablet regimen, there were again no resistance mutations that emerged for dolutegravir as compared to 4 who developed resistance to efavirenz. But in treatment-experienced participants, that may not be the case. Dolutegravir was clearly superior to raltegravir when in people who had prior treatment and who took these drugs mostly with boosted darunavir in the background. But there were 4 participants in whom resistance emerged to integrase inhibitors in the dolutegravir arm, including 2 who developed what now seems to be the canonical mutation for dolutegravir, the 263K that was described by Mark Wainberg, as well as a participant with the 148S, G140S dual mutation. And so, by comparison, there were 17, or roughly 4 times as many, who developed resistance to integrase inhibitors in the raltegravir arm, and that was statistically significant. If you use dolutegravir in highly treatment-experienced patients, you can see that the fold resistance increases with more mutations, particularly when 148 is combined with other mutations, but there's much less cross-resistance if only the 155 mutation is present or when other mutations, such as the 92Q mutation that might be selected by elvitegravir, are present. Well, what about cabotegravir? So cabotegravir is an analog of dolutegravir. The two drugs have similar preclinical profiles, and cabotegravir, as Ian has introduced, is well suited to use as a long-acting suspension that can be administered intramuscularly for injectable therapy. In the initial phase 1 studies, what you can see is that when given as a single injection, there is indeed a very long tail. Now, this is not steady state because this is only a single ascending dose study. But if you look here at these upright open triangles, this is the 400 milligram IM dose, and that's significant because this is the dose that's moving forward in the Latte III registrational study, and that group is shown here. And if you follow this out, you can see that out to 32 weeks, you are above the protein-adjusted IC90, and then at 48 weeks, there's clearly still detectable drug, and it's only a little bit below the protein-adjusted IC90. So you have drug that's going to be at an inhibitory but not fully inhibitory concentration. Now, as I'll show you in a moment, the drug is going to be dosed every 4 weeks so that if taken as prescribed or as directed, the drug should easily span the dosing interval. The question is going to be what happens when patients are non-adherent. So here are data from multiple dosing, looking at every 4-week or every 12-week administration, and you can see that in either case, you remain comfortably above the threshold concentration at trough. The drug is, and so one could imagine cabotegravir itself being administered less frequently than once monthly. I'll leave much of the detail on this to the next talk, because Courtney is clearly the expert in the pharmacology of these agents. But the results of the Latte 1 and 2 studies have really driven the subsequent pivotal trial to look at monthly dosing, not only because of cabotegravir, but really because of the rilpivirine component. So in Latte, which was an oral dosing study, which a necessary precursor to a long-acting injectable study, 3 different doses of cabotegravir together with rilpivirine at 25 milligrams were explored and compared to standard doses of efavirenz. And overall, the results were comparable across the 3 arms. In fact, the 3 investigational arms, at least numerically, outperformed the efavirenz arm, although the differences were not statistically significant. But the main issue is that there was virologic failure observed in Latte. In the cabo arm at the lowest dose, there were subtherapeutic levels of both rilpivirine and cabotegravir in that participant, suggesting imperfect adherence. But that patient did develop a 148R substitution in the integrase gene that conferred 3-fold resistance to cabotegravir and 30-fold resistance to raltegravir, as well as the key resistance mutation for rilpivirine. 2 other participants developed failure with rilpivirine resistance, but without resistance to the integrase inhibitors. In one case, it wasn't present. The other case, it wasn't tested. It's actually quite difficult from the published paper to sort out precisely what happened with respect to integrase inhibitor resistance in these other 2 participants. So Latte II is a injectable study, as a study of injectable maintenance therapy. Patients initiated treatment with oral dosing. They then had rilpivirine added at the end of the oral phase as a lead-in to exclude intolerance to any of the agents, and then were randomized to either continue oral dosing or switch over to 2 different injection regimens, either 400 milligrams of cabo with 600 of rilpivirine given monthly, or 600 600 of cabo with 900 of rilpivirine given bi-monthly. And the results show that there were, although the success rates were comparable in all three arms, notably there were many fewer virologic failures in the monthly dose arm compared to the every other month dosing arm. And based on these results, the phase 3 study is moving forward with monthly dosing. Oops, let me back up here. There are as yet no resistance data from the trial. You can imagine with only a single virologic non-response, there really aren't meaningful resistance data that are going to come out of Latte II thus far, and so we really need to see what happens in the phase 3 pivotal trials. So I think to summarize, as Ian mentioned, there are a number of important advantages to injectable therapy. And instead of having to take daily therapy, you could have once monthly administration. These injections have been well tolerated to date. I have to say, having lived through the enfuvirtide experience, although that's quite different, it was twice daily injections. Patients had to reconstitute the drug. There were a lot of challenges, but there were no dropouts from the phase 3 enfuvirtide trial due to injection site reactions. And injection site reactions became the major limiting factor once the drug was approved and on the market. Certainly, monthly dosing is more convenient than daily administration, but again, as Ian introduced, we're now seeing our adherent patients just twice a year, and intramuscular injections can't be self-administered, and so the need to come in or have a nurse or health care worker visit you monthly to get your shot may not turn out to be as convenient as thought. There is clearly less stigma associated. It's interesting that that was a prominent part of Ian's talk, and I've included this here as well. And it could be that adherence would be better with monthly injections because you won't have to worry about the patient taking the drug every day. And there's the potential, at least, for directly observed therapy. I think, to me, the greatest use of these injectables would be for difficult-to-treat patients, but at least in the United States, the only way that would actually make a difference is if we also invested in the resources needed and changed the mindset that had a workforce that would actually go out into the community, find the non-adherent patients, and administer the injections to them in their home or at a convenient place. And there's potential stigma associated with that as well. And the reality is that, at least in our practice, where about 80% of the virus loads are undetectable, the 20% of people with the detectable virus loads are the ones who only occasionally show up for their visits. And so the real challenge is, how do you find and administer drug to people who may not be adherent to follow-up visits? So the disadvantages of injectables are that they require currently intramuscular injection, although implantables would be a big step forward. We don't know about the long-term tolerability, as I mentioned. Now, then I think we do have to be concerned about the very long terminal half-life. In the cabotegravir prevention study that is now planned through the HIV Prevention Trials Network, there will be a 1-year tail of oral tenofovir FTC or Truvada to cover the pharmacologic tail of the injectable. And the real concern there would be if participants drop out of the study, they will and stop coming back for follow-up visits. Will they indeed adhere to this tail? And that's for prevention, where to date resistance has really not been a major issue in any of the oral PrEP studies. But where you have an already infected person, if they stop coming back for care and drop out of care, there is really going to be concern about selection for resistance. And I would have to say at this point, I'd say the risk has not been quantified. It is almost certainly a real risk, and we won't know what the impact of that risk will be until we have more experience and whether there will be then ongoing transmission of those viruses that do develop resistance. And so I think the fact that these drugs can't be self-administered and the potential for resistance in the non-adherent patients has to be grappled with. And with that, I think I'll stop and turn the program back over to Linus.